Hello, everybody. I'm Paul Yeager. This is the MTOM podcast, a production of Iowa PBS and the Market to Market TV show. The economy is what we talk about pretty much all the time. Rural economy, we talk about rural issues. We look at what's growing, what's not, but we also, every once in a while, look at housing, banking, finance. How about healthcare? Specifically mental health care. We're going to look at a new study done by the Common Sense Institute. Started in Colorado, but it now has an office, you could say, in Iowa. And they had a study that they conducted this summer that looks at healthcare options in Iowa, specifically in rural locations. We're going to talk with Chelsea Lensing. She's an economics professor at Coe College. She's the lead on this study, and we talked to her about just different things that they looked at. It's interesting from someone who grew up in rural Iowa, who lives in an urban county now, and just how different certain places can be, and even how different largely populated counties can be. 77 of Iowa's 99 counties have a story to tell, and that's what we're going to talk about in today's MTOM podcast. A reminder, we do have a newsletter. Go to markettomarket.org, click on just the front page, sign up for our newsletter, and every Monday you'll get some ramblings from me. Not ramblings, I make sense of what we're talking about, but just learn some details about the show, some inside information. It's called the Market Insider Newsletter. We'll see you on the other side of this discussion. Now, let's get to it. I only say this because I know this, but what was your first interaction with Market to Market? We're having our 50th anniversary, so everybody's going to get that question now, but I understand you've known about the show for a little while.
Yes, I married into a farming family. So my husband is now a third-generation farmer from northeast Iowa, and so his dad watches it every Saturday morning. Usually that's when they watch the Friday program. And so then now in my whole household, once we were married, that comes on the TV every Saturday morning for us. Now we have two girls, and now our 3-year-old knows it's Saturday morning. Okay, let's turn on Market to Market.
We're like the morning cartoons. I'll be more animated then. Would that help?
Yes, we would appreciate that, definitely. Keep her attention. She likes the intro music, the first, ad or so, and then her attention fades a little bit, but that's okay, yeah.
That's all right. Halfway through the show, people think my attention span goes. I just sit there and let people talk, but it's okay. But he grew up on a farm. Did you?
No, I'm from just south of Des Moines in Indianola, so there's definitely some farming communities down there, but I myself did not grow up on a farm. So I'm still very new to, the farming community and the farming world, but it's been a great experience. My husband and I, we met in college, and he was in business and economics and finance, so we came from the same academic world, but have taken two very different paths with that. But we probably talk about markets in general in our household way more than the average couple or family. But it's really fun that we have a similar interest, but he is more interested in the financial part of things and the ag markets, where I am a health economist, and so my area of specialty is very different than his.
Well, okay, so if the specialty is different, but how similar are economics? Put whatever adjective in front.
Very, extremely. I mean, they're all centered on the same principles, the same foundations, and, especially when it comes to, critical thinking and even applying those skills outside of, these specific fields of economics, there's a lot of overlap there.
But he's not actively involved. You're not actively involved in farming right now.
No, so my husband is. So he is.
Oh, he is?
Yes, he is.
Oh, okay.
Yeah, he's currently an engineer at Quaker Oats at the factory here in Cedar Rapids.
Mm-hmm.
And so that's his, his day job, I guess, if you will. But he saves up all of his PTO to then go farm with his dad up north. We crop farming. They used to do some livestock, some cattle, but now it's primarily crop farming. And so during harvest and during planting, he's taking those vacations to go up there, and so we'll spend a week or two up at the farm. So he's helping his dad. It's a partnership up there.
Well, that gives us a whole lot of endpoints here in how we can in what I want to cover today. So your interest in economics came from where?
Kind of by accident. I did my undergraduate at Coe College, which is where I now currently teach economics, and I was a math major, but had no idea what to do with this math major and that skill set. And I took a Principles of Macroeconomics class as a general education course, just because I thought, honestly, it might be kind of easy. And then all of a sudden I could see all of these mathematical tools could be applied to something that in my eyes was a lot more interesting. And at the graduate level, economics is way more math intensive than it is topic intensive or content intensive. And so I was very competitive when I was going and applying to grad schools because I already had that math major. And so I had those skill sets that are a little bit more challenging to teach once you get to the graduate level.
And then your class, what's your base class that you teach? I mean, what's your, I guess I'm supposed to, there's a term for it. I want to say CVI or something. I mean, what is it that you teach? What are your classes?
So I teach a wide range of classes at Coe. We have a relatively small department, being a small school, and so all of the economists are pretty diverse. I teach primarily within the fields of microeconomics. So principles of microeconomics would be the intro-level courses that I repetitively teach, but then I also teach international trade. I teach intermediate microeconomics, and then since my area of specialty is health economics, I've actually created 2 courses here at Coe that are specifically on the topic of health economics, which tend to fall within the micro field. And then I also teach some upper level analytical courses, econometrics 2, regression analysis, so teaching the toolkits of how do we actually utilize and implement data.
And health is the next road in. You have like most professors, you have other things that you kind of get into to help. Common Sense Iowa, where did that partnership come with you and them?
Yeah, so Common Sense Institute is a nonpartisan research organization that's focused on promoting and protecting the economy of Iowa. And they were originally founded in Colorado, but they opened a branch here in Iowa just earlier this year in January. And so they had reached out to me. The CEO is actually a former Coe graduate, and so there was a little bit of overlap in networking there. And she knew my area of specialty was in health economics, and so they approached me about partnering on a project this summer that was focused on just understanding more about the healthcare landscape in Iowa. A lot of what this research organization does is focused more on inflation and jobs and policy evaluation, but they know that healthcare is such an important part of all aspects of our lives, including the economy. And so they were hoping to produce a report that describes what's going on in healthcare, not just in the country, but specifically here in Iowa. We have a lot of rural areas that are different than when we just look at national trends. And so we wanted to be able to provide a report that was comprehensive in describing what's going on right now, what are we doing well, what are the challenges, and how do those challenges differ based on where you are in the state.
Well, that's easy. You asked your own follow-up questions. What are we doing well right now?
Yeah, that's a great question. As we were writing this report, when you're just looking at certain health outcomes of the healthcare system, or whether it's individual health outcomes, it can be a little bit challenging to not feel like, oh no, everything is moving in a bad direction. And there definitely are some real challenges at the absolute level, but then when you look more broadly at what Iowa is doing in comparison to the rest of the country, we're actually doing pretty well. So what we found at kind of a big picture level was that there's a lot of challenges that Iowa is facing, but we're holding up pretty well in comparison to kind of what everyone is facing in the country.
So we're not unique, but there are challenges, and I'm going to guess the challenges are there's not enough access to care for everyone, and maybe urban areas are more opportunities than rural areas. Does that hold up?
Yes, yeah, absolutely. One whole section of the report that we looked at was the differences between urban and rural communities. And there's a whole bunch of ways that you can measure access to care. So there were 3 primary ones that we had looked at. We looked at primary care physician rates, we looked at facility opening and closures, and then we looked at more of an intensive margin of supply when you think of hospital beds and department closures. So that first one, the primary care physician rate, so that's adjusting for the number of primary care physicians for the number of people, right? We would expect there to be more primary care physicians in the more populated areas because there's more people, but even once we adjust on a per capita basis, we see that there's significantly more providers in these urban areas. So if you split all of the counties in Iowa into urban and rural, which the USDA has definitions of what constitutes urban and rural, 77 of our counties are considered to be rural. And if you look at trends in the number of primary care providers between these two types of counties, over the last 10 years, for urban counties, we've seen about a 1% decrease in primary care physician rate. But for the rural counties, we've seen about an 8% decrease in primary care providers. Again, this is already adjusted on a population basis. So we're seeing a much larger decrease in the rural counties. But even further than that, counties are not just urban or rural. Even within the rural counties, we have 22 of those 77 counties have 100% of the population living in a rural area. So if you take those more extremely rural counties and you compare them to the counties that have, say, fewer than 20% of the population living in a rural county, there's about double the amount of primary care providers in those urban counties than what we see in the more extreme rural counties. So there's a really big divergence when we are looking at primary care physicians as a measure of access to healthcare.
Let's go where you grew up, south of Des Moines. Indianola is a city of 10,000. But I'm guessing in the outer areas of Warren County, there are people who are 30 minutes from care that they could have, and or even in Lynn County where you're at now. So that's what you're talking about, is you might be inside a county, but there's a chance you're outside of this area, not golden circle, but golden area of where there's better and more access to care. And that is an issue that maybe gets lost in the data.
Yes, yeah. So essentially, the higher percent of individuals you have that live in a rural area in a county, the lower the options are for care. So we didn't necessarily look at driving distance as a measure. There are previous reports who have done that, who have looked at, for example, based on where you live in Iowa, how far you'd have to drive to a level 2 hospital. Again, that wasn't something that we specifically focused on. It was a hard choice to figure out what to focus on because it was such a broad report. But again, yes, it gets at exactly that measure you were talking about.
And is there a certain type of care that is falling short here that we're losing access to?
Yeah, so again, primary care physicians, that's one of the main metrics that we looked at. We also did some work to try and understand kind of where things may be going with our workforce in the future. We're already seeing shortages of nursing staff in hospitals. We're seeing a shortage of what we would consider to be low-wage healthcare positions. So we already seen those shortages now, and those are projected to grow in the future. We also looked at the average age of provider specialties as a measure of, how old is that type of provider on average, because those older providers will be aging out of the workforce sooner, and we will need new providers to prevent shortages. So, for example, again, if we go back to this idea of a family care provider in comparison to a nurse practitioner, we see a lot more nurse practitioners coming into the healthcare environment, and then we see a lot fewer family care providers. We also see a lot fewer of some other types of specialties, including OBGYN care in rural communities. But it's something that we can, hopefully policymakers can look at that data and kind of see, okay, where are the areas that we might be seeing more shortages as we're moving in the future?
Is there any type of thing government can do to help in those shortages? I mean, you're talking about them examining and looking at those things. I mean, we hear about, this will help recruit doctors and nurses. This will help. Is there anything realistically that can be done?
Yeah, that's a great question. So at the end of the report, we did identify a few policies that Iowa lawmakers have put into place just in the last couple years, and some of those are specifically focusing on trying to get more healthcare workforce into the market, and especially concentrating that in these more rural areas. Some of those include, financial help with with schooling if they practice in a rural community. Some of those are targeted at certain specialties, again, such as OBGYN, but some of them are family practices, and those have been more recent policies that we've identified, and so it's unclear yet what the effect of those is going to be. This is another hope that, either other research groups or potentially Common Sense Institute can then take the report that we have created as a baseline of where are we now, and then once these policies hopefully have time to be implemented and have an effect, we can do some sort of policy analysis to see whether or not we really are making an impact.
All right, now you get to put your economist hat back on. When it comes to workforce, we hear about, there's always this push of we're sending everybody to a 4-year school. They need a white collar job. But then you start to hear no, we need to have a whole bunch of skilled trade. We don't have heating and air conditioning techs. We don't have tool and die makers. We don't have that. We don't have, it sounds like it also needs to be included into home. I mean, we grow things in Iowa. We need to be able to grow healthcare workers too. Is that what I'm picking up that maybe is that possibility?
Yeah. Encouraging individuals to go into the healthcare workforce is definitely something that we can that we can encourage. When we compare Iowa to other states, the projections on how big our shortages are going to be in the healthcare workforce, when we look at things like nurses, mental health, and low wage healthcare workers, Iowa is actually looking pretty good on mental health care workers. The nursing shortage is a real problem for Iowa moving forward, but it's still a lot lower than what a lot of other states are facing. So I think there's some case to be made that we're doing a pretty good job of attracting and producing those types of workers in our state, but something that we need to continue to do, whether that's providing incentives for Iowa residents to go to school in these specific areas. That's hopefully that will continue to help fill the pipeline of healthcare workers.
Before we get to mental health, I want to go one thing that I've heard as a possibility that is assisting to this is the telehealth, the using your phone. I've had an experience where it was a Saturday, late in the evening with the child, and I guarantee my doctor was somewhere in California or somewhere not. I mean, how is that helping? Or even is that being counted in how you can do research here of getting care for people?
Yeah, so telehealth is an interesting beast for a couple reasons. It's relatively new, and we don't have a lot of great data on it. So we saw a huge increase in the use of telehealth because of the pandemic, and so those numbers spiked. But it really wasn't until the pandemic that these federally administered surveys even started tracking telehealth. And so, the data sources that we have out there right now are usually coming from private sector companies. Usually, insurance companies are the ones who have that data. Because even when we look at providers, it's where are these providers registering with Centers for Medicare and Medicaid on a physical business, and there's not a lot of standardization as far as how much of telehealth they provide. The information that we do have, it definitely shows that increase during COVID. But since then, if you look at 21 to 2022, we actually saw a decrease in the use of telehealth. So it seems like we saw this big spike up during COVID. It's coming back down a little bit, but it's still way higher than the trends that we were seeing pre-COVID. So currently, about 30% of U.S. adults say that they have used telehealth within the last 12 months, which is still a pretty significant portion of them. Again, this data is looking at the national level, so it's not specific to Iowa, but there's a report out by the National Health Institute, actually I think just a month ago, a pretty recent report, that looked at the usage of telehealth and how it related to the metropolitan nature of where they lived, right? So how populated is the area? And this report was showing that the more populated the area, the more likely individuals were to use telehealth, which is really interesting because you would think it's the individuals in the less populated areas that are wanting to use that. But this report also showed that there's a really big relationship between age and use of telehealth. And so we know that the population of our rural counties is also tending to be older, right? It's aging faster. And so this report was not causal by any means, but I would personally assume that a lot of that relationship has to do with both where you live and age and access to that. There's also a difference in employers and whether or not they cover telehealth. And so in larger cities with larger employers, you might have an insurance plan that is more likely to cover that type of service than you do in a smaller town with more limited insurance coverage. So again, we don't have a lot of great data to tease apart what's going on in Iowa specifically. We're kind of deducting from the national trends here.
That's fascinating, though, to think about that the one who could probably go down the corner and look in one direction or another in a suburb and see a clinic that they could go to, but instead they'll stay in their house and use their phone. Anyway, that's another subject for another time. Mental health coverage in Iowa. Again, one of those things that we always hear uh, on a show here earlier this spring on Iowa PBS. It was a sheriff from Blackhawk County who talked about that they have become almost a de facto mental health treatment option for the mentally ill. What are we finding? Is there a theme in Iowa about mental health care, rural versus urban, or does it even matter? We just have issues.
Yeah, so the two ways that we were looking primarily at mental health access in Iowa is through the number of facilities and then through the number of providers. And so I'll start with facilities, and we looked at facilities that were overseen by the Iowa Department of Health and Human Services. So it doesn't include all facilities, but it includes a lot of mental health care facilities such as community mental health, more like long-term or rehabilitation mental health, and those types of facilities. We've seen a significant increase in the number of closures and hardly any openings over the last 10 years. And so these dedicated mental health centers are closing at a concerning rate. And so that's one area in which we see a big decrease in supply for mental health. But at the same time, we're seeing an increase in the total number of mental health care providers on a per capita rate. So, for example, even in rural counties, over the last 10 or so years since 2015, the number of mental health care providers per capita has doubled. And so even though it's still only about half of what we see in the urban counties, there's still a big gap between urban and rural counties, we're making a lot of progress. But again, it kind of stands in the face of all of these closures of these specific mental health care facilities. And so it really depends on the type of mental health care that individuals are seeking, and where exactly those centers are. So, I do think telehealth has a great opportunity to help bridge some of those mental health care gaps. It's one of the health services that is relatively easily administered through an electronic platform.
You can have conversations if it's therapy. We'll just start with the simple thing. Therapy via phone. Sometimes people will feel more comfortable in their home, and it might be easier to do. So that's that. I'm thinking that's what you're referencing there.
Yes, thank you for clarifying. Yeah.
Well, I'm slow a lot of times. I have to ask a lot of questions. That's why they give me a microphone, because I ask a lot of questions. Chelsea, what about the care that's maybe a little more in depth with someone who might be manic or someone is in a tough spot? Are you, what can any survey say? We just need to focus on this, and this will help this issue.
Yeah, so again, that's an area where we're losing the supply in Iowa in general. We did find that it was a relatively even amount of closures between urban and rural communities when it comes to these healthcare facilities. So it's not just a rural problem, if you will, or challenge that we're facing, but it is, it limits the access for, like you said in that scenario, for where that person can go, right? If that person is going to a hospital or ends up calling the police, and so the first responders are then acting in that capacity. Those with, long-term intellectual disabilities, as adults, there's fewer places for those individuals to seek care, and so they're having to stay with their families longer, or, finding other options. And so that's definitely a concerning area, especially hopefully policymakers can focus in that going forward. If we are seeing these net closures of these types of facilities, what other support can we get for these individuals?
Is there any, I won't say magic answer, but is there something that a strong recommendation that can be made on what would be an ideal, a Pollyanna answer, I guess? Let's give it.
Oh gosh, well, sometimes I feel like if I had the answer, I'd be, working in the White House.
Well, but sometimes the answer is there. It's a matter of funding. So right now, unlimited funds can create your answer.
Yeah, I mean, yeah. So if the state was going to say, yes, we're going to up our funds for any, even any hospital who wants to expand or put an additional center on their existing facility that is going to be specifically inpatient or long-term care for those struggling with, whether it's, acute or chronic mental health conditions, funding is definitely something. It also, we get into the weeds a little bit when we think about reimbursement rates and who's paying for these, right? So if reimbursement rates are relatively low for these types of services, that's also going to decrease the motivation for suppliers, which in this case is, hospitals or doctors, to open these types of facilities. So it's not necessarily just the startup cost of getting it going, but also how we're reimbursing these providers.
Back to the money. Always back to the money. Any economics tie to mental health and what that does to an economy? Do we know anything in those fields?
Yeah, and there's a lot of evidence from an economic perspective to that ties together when we're having an economic downturn. So when we're having higher unemployment, things like that, we tend to see higher rates of deaths of despair, which are also related to mental health of individuals. Deaths of despair can include things like suicide, but also excess alcohol consumption, opioid or other drug consumption. And so we're in a unique time right now because the economy, unemployment-wise, is doing pretty well, especially in Iowa. We have really low unemployment, but our labor force participation rate is actually continuing to go down. And so we're having more people leaving the employment market, and we're still dealing with pretty high inflation. And so we're at this really kind of unique spot that is different than a lot of the previous economic downturns that economists have studied. There's also, of course, the opioid epidemic that we've been dealing with that has increased even more, so been exacerbated since the pandemic, and that's leading to, or is one of the drivers of the increase in premature death that we see. That was one of the areas that we did talk about in our study. We weren't focused primarily on health outcomes, but premature death rates was something we did identify in the rule section, the rule focus of the paper, because not only are we seeing an increase in premature death across the state, it's substantially higher for our rural communities. So the absolute rates are higher and the increase is higher for these rural counties. And so even though if you're just looking at measuring our economy with the unemployment rate, that might not be telling the whole story, right? And something else is going on here with our rates of premature death. And again, we don't have the data to parse out how much of that is due to mental health, but I think it's all extremely related, right? How individuals are feeling, how they're dealing with the economy, how they're dealing with family life.
Well, and that's what I was going to ask is how recent is your data that you're referring to there?
Yeah, so the data for this report, we tried as we got the most recent data we could to our extent for the report. The data sources we collected them from a lot of different places, which I think hopefully for viewers, if you're looking for a place that synthesizes a lot of data that's out there, this is a great resource for that. So this data on premature deaths is through 2024, but the 2024 estimates are using a little bit of lag data. So the county health rankings uses kind of a moving average, but it is the 2024 estimates of the current premature death rate. So it is relatively recent data, I would argue.
Yeah, I would. That's when you said 24. That gets my attention in a hurry. So, are you seeing a higher rate of premature deaths in Iowa right now than say, or even 23 to 22?
So if you just look at an absolute level, it's lower than the average that we're seeing in the country. We saw similar trends when we looked at how Iowa was impacted by the fentanyl and opioid epidemic, where, yes, we're seeing this increase in opioid-related overdoses, which is also contributing to the rise in premature death rate. And so it is something we need to be concerned about, but compared to other states, we're still doing a lot better. And so again, it's this kind of weird dichotomy of this is a challenge and we need to address it, but at the same time, we need to be cognizant that we're doing pretty well given the atmosphere that we're in.
Well, that's kind of where I'm going, because we hear wherever wherever here is, oh, it's bad, or it's not good. But you mentioned it, low unemployment, stock market is record levels. I mean, other things, but yes, inflation still stands out there. But again, that's historic, not or recent, not historic levels. We're not talking like the 1970s or early 80s here with this. Do we lose some of that perspective, and does that cause us? It's not mental health, but just it's fatigue on understanding if we are in a troubled time.
Yeah, that's a great perception, a great question. And we didn't look at any data that was teasing out the perception of the economy and what's actually happening. I think just from my understanding of kind of our culture in general, this is also a very divisive time, right? Social media exacerbates everything, and we're talking about mental health here. If you look at the studies that link social media use and mental health, there's significant evidence that the more time we spend on social media in any manner, the worse our mental health outcomes. And so, it's something I think to be cognizant of, because like you said, even if we're doing pretty well, if you're getting all of your information from one source, or you're only looking at all the negatives kind of in a silo, it can be hard to have that more comprehensive picture of, but there are a lot of things that we're doing well on, and we're seeing an improvement in these areas. And whatever sort of, whether it's politically divisive, or there's healthcare issues are very divisive, right? No matter your political leanings. And so I think that can be very challenging for mental health on everybody. And so I do hope to kind of having a broad picture of what's going on in the country and where Iowa fits in that can be helpful.
Because the Michigan sentiment outlook to me is always interesting. The Purdue sentiment, those are to me much more opinions. I know there's facts based in them, but perception and sentiment and uh, personal situation are all in this blender of what we choose to believe is happening right now. And that to me is a frustration of trying to parse together information to present to people. So that's just you've just opened up my hat now and looked in my brain, which is not what you wanted. Where do we go next? What is there going to be next studies year after year? Is this a one-time thing? Is there a new leaf that you want to go out on the branch?
Yeah, so again, this was my first experience with Common Sense Institute. I had it was a great team to work with and lead, and I hope that I have an opportunity to do it again. I definitely think, in teaching in the classroom, I've given some talks, that are more community facing on healthcare economics, the U.S. healthcare system, and some of the questions that I get most frequently are, well, how is Iowa different? Or what's going on in Iowa? And until I had the chance to really sit down and dive into the state level data and even county level data, I didn't really have a great answer for that. And so that's been really nice and opened my eyes to be able to compare, yes, this is what's going on nationally, and here's where Iowa is. But there are definitely quite a few pieces of this that sparked my curiosity of, oh, well, we could do an entire report on, about 20 different things that we identified in here. One of the areas that was interesting to me is that we found that more than 20 of the hospitals in Iowa have been purchased by a larger healthcare system over the last 10 years. And now there's a federal mandate that all hospitals have to post their prices for price transparency. It's not always the easiest data to use, but it's out there. And so that could be a really interesting project to understand how it's affecting individuals in their billing and the prices when these larger systems are buying up the smaller hospitals, especially in the rural areas where that's the only option to go to. So that's one area. Another one that I personally am interested in is maternal and infant care in Iowa, and especially in rural Iowa. So we have, out of the 77 rural counties, only 62 of them do not have a practicing OBGYN. And so that's a big provider shortage. And in addition, 44 of the hospitals in Iowa have closed their maternity or birthing wing in the last 10 years. And so even though we don't have hospital net closures necessarily, the opportunities for these specialized care, especially for mothers and their infants, is dwindling. And we are seeing an increase in nurse midwives as a supply in the state, but they're not necessarily concentrated in the areas in which we really need the care. And so that's definitely an area of interest of mine moving forward.
The supply doesn't meet the demand, and it's back to your what you learned in Economics 101.
Principles of micro. Yep, I gave a lecture on supply and demand this morning.
When you say what your students were asking, were those questions from already this year, or are you talking just in general what students have been asking about the economy? I'm kind of curious what they're asking right now.
Sure. About when I am talking about the healthcare system and what's going on in Iowa.
That, and just the economy in general.
Yeah. So I was referring specifically this. It would have been in March, just of this last year. I gave a forum, which was a 4-week series where I'm essentially lecturing. It's public facing, so people can pay to come to these lectures that are primarily given by co-faculty. And so this was a group of, I think there's around 200 or so community members there. And so those were the ones that were primarily asking questions about, well, how is, okay, here, this is a great picture of the country. What's going on in Iowa, right? Mm-hmm. And so those were the community members who were most interested in that. In the classroom, I would say I haven't probably gotten too many questions this first week of class. I feel like it's mostly introductory material. I think that students are definitely interested in what's going on, and I try and really warm them up to be asking just those, like, hey, let's have a conversation. Let's just talk about what we're interested in. But sometimes that first week of class, it's hard to get them to let down their boundaries and just have a conversation outside of what I'm lecturing on.
You just tell them that there's a couple of bonus points if they ask a question, but then that's flooding the market with probably information you don't need.
Yeah.
All right, Chelsea, I appreciate your time. Thank you so very much.
Yes, thank you so much for having me on. It's been great to chat with you, and I look forward to watching the show on Friday.
My thanks to Chelsea Lensing. Go easy on that TA this fall, if you could, please. New episodes of the M2M podcast come out each and every Tuesday. We will see you next time here on the M2M podcast. Bye-bye.